you asked me to speak about the IOL complication. First, you're going to speak about the preloaded IOL tracks. The preloaded implantation injector system, and the IOL is shipped and unfolded, and then unfolded into the inserter. The advantage is there is no manual handling, so reducing the contamination and increasing ease and reliability of folding process. There is 3 techniques. Through the wind into the anterior chamber, the wind-assisted technique, and the wind optimized technique. 2 types, with rotation, especially for the 3 pieces IOL, and flat injection for the monoblock ones. If you are starting IOL implantation, try to see videos first, learn about the IOL, notice first use out of the eye, and proceed at loading at the last minute before you can rinse preloaded hydrotic IOL injector with BSS, use large incision, proceed slowly into the injection, and you can use a hook to stabilize the eye and to place the IOL into the anterior chamber. You have to take care about the IOL optic for the optical quality and of the optic for the stability of the IOL. Through the wound technique is the most common one, and it's the one for the 3 pieces IOL. You have to be inside into the anterior chamber first, then you can inject the IOL. We can do it even for with the monoblock IOL, and this is the easiest technique to inject. The wind-assisted technique is the advantage are the incision remains small, and the injector is just placed in front of the incision, which is in continuity of the injector. The globe is stabilized by a second instrument, which is recommended, and the injector is positioned in the axis of the incision. And once the optic is in the anterior chamber, at that moment the injector can be oriented to the bag. Then the IOL is placed into the anterior chamber in one step. We can have some complication as the IOL was looked into the incision or injected outside, so you have to take it out and reload it and to remain in contact with the incision. The optimized technique is the technique behind the 2 previous one. We can have some difficulties with and have injector damage like blocks or bursts, or we can have IOL damage in the optic like marks or stripe, or in the haptic like wrench and rupture. So we have to explanate the IOL to change it, and if not, it's going to be a problem of stability. We can have some eye damage like incision gap and capsular rupture. For sulcus implantation, we have to know that the sulcus has an oval shape, which is not the same as the cornea because the vertical axis is bigger. So the IOL should have a total diameter of minimum 13 millimeters with 6 millimeters diameter for the optic and 3 pieces. We cannot use square terminated lens optic edge because they are inappropriate dimension for sulcus. We cannot have a good centering, so there would be iris posterior epithelium ribbing with pigmentary dispersion and risk of glaucoma. Then we can have iris atrophy with recurring hemorrhage and inflammation. With sulcus implantation, it depends. If we have a posterior capsule intact, we can just start with the haptic inside the sulcus first. If not, we should put first the implant in the anterior, in front of the iris first, then to proceed to place it with a second second-hand instrument. For presbyopia IOL, there's 10 principles. The first one concerning the patient have to be motivated, positive and optimistic personality to avoid postoperative disappointment. And he must understand that and be willing that to be patient with the process. As you see here, this is the glare and haze around the light and the trees just after the surgery, and 3 months later, everything doesn't disappear, but very low. Third, the surgeon and staff must assess vision function needs and goals and proceed to photopic, mesopic, and scotopic lighting levels to select the best multifocal IOL design. Of course, you have to perform an accurate IOL power measurement, and if the astigmatism is greater than 0.75, it can degrade the quality of the uncorrected vision, and it's preferable to use a toric presbyopia IOL. Multifocal IOL is avoided in eyes with maculopathy or amblyopia, and in glaucoma, especially with central visual field loss. Don't miss the ocular surface because it's the dominant optical element in the eye, so we have to carefully preoperative assess the aqueous tear deficiency and meibomian gland disease. So we have to pre-treat those conditions. If it cannot be treated, presbyopia IOL is not the best choice. Eighth, the surgeon should be high skilled. I mean, the implant the capsular access should be well centered and correctly sized, and proceed to the very good cortical removal and intact capsular bag. However, patient should be aware that complications do occur and may lead to a change in the choice of implant. We can proceed to staged implantation, I mean 2 weeks between the two surgery, because the visual function of the first eye can be accurately assessed. More time if uncertainty about the outcome of the first eye. Surgeon can optimize the IOL power selection, and we call this a custom matching or mix and match. And finally, don't promise. Then that glasses will never be needed, and under-promise and over-deliver. And don't forget to celebrate the success. For toric IOL, we have to consider determining the targeted astigmatic correction preoperatively, and to consider the fellow eye refraction and patient desire. If you plan to put a multifocal IOL, it's better to put a Toric one if it's larger than 1 diameter astigmatism. To avoid flipping the axis, it's better to undercorrect rather than overcorrect. And irregular and asymmetric astigmatism are not compatible with the toric IOL, so you don't use it. For the plate toric intraocular lens injection, first you have to try to perform a non-astigmatic corneal incision, and we have to use a corrosive inflamed viscoelastic device, and to remove it, the one trapped behind the IOL to maximize prompt contact with posterior capsule. At the end, do not inflate the eye or the capsular bag and leave the eye softer than usual. That allows capsular bag to collapse around the lens more quickly. Capsular bag begins to contract in the first day. So the first day exam dilation should be performed, and if the implant has moved, we can perform second surgery, but in the first operative week. And don't miss, plate phakic IOL should never be implanted in the silks. For the toric Acrisoft, the only difference is that when the OVD is taken, it can disturb the position, so we have to replace it at the end of the surgery on the axe. To avoid posterior capsular ossification, you have to know that it's the most postoperative complication following cataract surgery, and it's the major case of decreased visual acuity after cataract surgery. And it occurs between 3 and 50% during the first postoperative years. 6 factors, the ones who are surgery-related factors, I mean, adjusted dissection and nascent cortical cleanup, in the bag IOL fixation and capsular excess should be smaller than the diameter of the IOL optic. And factors related to the IOL are biocompatible IOL to reduce stimulation of the cellular proliferation, contact between the IOL and the posterior capsule and IOL with a square truncated optic edge. For hydrodissection and nascent cortical okay, I just want to show you some example of post-mortem IOL inside the eyes. This is a case of hydrophobic IOL. We see that there is only one layer of cell, which is almost invisible. And in this case, it's a little bit much more, and here much better. In the case of silicone IOLs, we can have very important migration. So the importance of the square truncated lens optic edge that which acts like a barrier to prevent migration of preservative materials. Here is an
Dr.
example.
Kadal, the time is finished, please.
It was my last tip. Thank you so much.
Thank you.